All right, we can get started as soon as we have a quorum. Probably about 6 more minutes, hopefully. Good morning, Tyler. Good morning, FloCon.
Good morning.
Morning, Julia.
I don't know if someone said anything yet, but Babette Bond, she emailed me, said she's going to be late around 10 o'clock.
Yes, she did. She let me know. Thank you. Then we have Ryan, good morning, and Commissioner Grady, good morning.
Good morning.
Morning, this is Division of Public and Behavioral Health. Can you hear us here in our conference room?
Yes.
Okay, just
I hear
testing.
you fine.
Very
Great.
much.
Thank you. So it seems like everybody received my my Zoom invites this time. Seemed to work out a little better. Hello, Director.
Morning. So in a couple of minutes at 9 o'clock, Leslie, we'll take a roll call, see if we have a quorum at 9.
Yeah, I think we're good, but yeah, we have about 2 more minutes. I have to send the attorney something here.
All right, it's 9 a.m. Welcome everybody here, and we'll start with our roll call. And if we have a quorum, we'll proceed. Leslie, you want to take a roll call?
Yes, can everybody turn on their cameras, please? Sometimes I can see you even if I can't hear you. Thank you. Good morning. Okay, we will start with Commissioner Bond, who is going to be a little late, but she let us know that she'll be joining us in a while. Commissioner Lenitra Grady.
Good morning here.
Good morning. Commissioner Flo Khan.
Here.
Good morning.
Good morning.
Chair Khan.
Present.
Commissioner Leanne McAllister.
Good morning, I'm here.
Good morning. Vice Chair Sandy Rubelid.
Here.
Commissioner Dr. Beth Slamowitz.
Good morning, here.
Good morning. Dr. Slonim is also going to be attending a little late. Let me know that. Commissioner Dr. Tiffany Tyler Garner.
Present.
Commissioner Mason Van Helling. Okay, I saw him here. He's changed to, it looks like he's changed to his phone now. Commissioner Tyler Winkler.
Morning, present.
Good morning. Our non-voting members are Ryan High.
Good morning, present.
Good morning. Laura Rich.
I'm here.
Morning. Barbara Richardson.
Morning.
Good morning. Richard Whitley.
Here.
Good morning. Okay. Commissioner Roa Dugan is absent excused, but we do have a quorum, so we can start.
Thank you, Leslie. Appreciate that. Moving on. The next item on the agenda we have is the approval of January 19, 2022 minutes. I believe everyone got a copy of the minutes. I know I did. Leslie sent it to everybody. So unless somebody had any question, I would like to have a motion to approve the minutes. Do I have a motion from any commissioner?
I'll make a motion.
Mason Van Howling.
I'll
Okay.
second it. Leanne McAllister.
Okay, great. Any opposed? If none, the motion carries. Thank you. The next item on the agenda is a public comment. Leslie, do we have anybody in the north for public comment?
See, I have some attendees. Is anyone going to raise their hand to make a comment?
None?
I don't see any. Nope.
Okay, anybody online?
Not that I can see. I mean, I do see people, but nobody's raising their hands. So,
All right, anybody in the south?
no.
None? All right, thank you. Moving along, the next item on the agenda is the presentation on an update on the status of COVID-19 in Nevada. And this is to be done by the Division of Health and Human Services. So we have Kyra Morgan, Melissa Peak, Bullock, Julia P. Dave Wurst. Am I pronouncing that right? All right, so we'll proceed.
I believe.
Okay, so we'll proceed with that.
All right, thank you.
Sure. Can you all see my screen?
Yes.
Sorry?
Okay. Hi, I'm Kyra Morgan. I'm the state biostatistician for the Department of Health and Human Services. I'm going to kick off the presentation today regarding the status of COVID-19 in Nevada. And as mentioned, I'm going to be joined by Melissa P. Bullock, who is our state epidemiologist, and Julia Peak, who's a deputy administrator for the Division of Public and Behavioral Health. First, I just wanted to set the stage and show the data and kind of where we've been over the past 2 years. COVID-19 was identified in Nevada in early March of 2020. And since then, we've had really 4 distinct surges. There does appear to be seasonality on a biannual basis. We've observed a surge occurring each winter and each summer. And each surge has presented with unique characteristics that are largely driven by the differences in emerging variants, coupled with evolution of mitigation strategies that are available, and then obviously the utilization and adoption of those mitigation strategies. So in this graph, again, you can see those surges. The third one here, starting in July of 2021, is the one you might reference as being related to the Delta variant, and then the most recent surge on the far right-hand side, which, as you can see, just kind of pales the other ones in regards to magnitude, is related to the Omicron variant. Right now, we're averaging 739 daily new cases being diagnosed statewide. That's down from, as you can see, we had peaks of almost 8,000 daily new cases just about a month ago. Here we're looking at that same trend, but related to hospitalizations, which has closely mirrored cases throughout the pandemic. There's been, again, 4 surges that lag cases by approximately 14 days. The most recent Omicron surge, which peaked at the end of January, observed a much milder illness and resulted in hospitalizations comparable to last winter, even though we had much higher case rates. So today, yesterday, we had 865 individuals hospitalized in Nevada hospitals with COVID-19. And that is a trend that's declining statewide. Here we're looking at critical care hospitalizations. So these are individuals who utilized an intensive care unit or needed mechanical ventilation. And even though hospitalizations in January of this year were pretty comparable in the magnitude to previous winter, we don't see the same magnitude in regards to critical care, which I think speaks to a combination of vaccine availability in our population and also just a milder presentation of illness with the Omicron variant. This slide is looking specifically at COVID-19 mortality trends, which also lag behind new cases by approximately 21 days. We have found that hospitalizations are a more accurate indication of magnitude related to mortality than case trends are. That's pretty apparent. As you look at this graph, you'll notice that we've had much higher mortality rates last year than this year. Again, largely driven by vaccinations as well as therapeutics, which allow us to not only prevent infection, but also prevent serious, severe symptoms, hospitalizations, and mortality rates, and then therapeutics, of course, to be able to treat. Here we're looking at vaccinations. Obviously, we had a significant uptick in vaccinations when they first were made available. That kind of died off, and then we have seen various things kind of cause vaccination along the way. So when Omicron variant came out as being highly transmissible, we did see an uptick in vaccinations at that time, but for the most part, we're holding pretty steady. 53% of Nevadans are fully vaccinated. That does not account for boosters, and 63% have at least initiated their vaccination, which means individuals who have received at least one of a 2-dose series. So Pfizer or Moderna, we would count you as initiated if you've received even just one of those shots, although that doesn't constitute you being fully vaccinated. We also have on this slide measures specific to the eligible population. So the percentages that I've given so far are based on all Nevadans. If we look specifically at individuals in Nevada who are 5 years and older, which are eligible to be vaccinated, we have 56% that are fully vaccinated and 67 who have at least initiated. I did include a slide here, which really just kind of summarizes what I've talked about, but is designed to really draw attention to the differences in these different variants and how they've impacted the surges over the last 2 years. So this slide takes last winter as kind of a baseline, and it presents our trends as a percent of that peak that took place last winter. And so what you'll see here is that this portion of the graph here that is around August of 2021 That's our Delta surge. You can see new cases came in quite a bit lower proportionally to last winter surge, but daily deaths were much higher and hospitalizations were even much higher than that. So that is indicative of a variant that causes severe illness and has a higher impact on our hospitalization and our mortality numbers despite low case numbers. And then you could see just the vast difference of the Omicron surge at the far right, where we had significant magnitude of new cases, 200% of last winter, but we were still able to maintain hospitalizations at about 100% of last winter, and then mortalities are coming in even lower. So again, a combination of many effects related to both less severe strain of COVID, vaccinations being available to protect people from severe symptoms and mortalities, and I think just progress being made in general towards mitigation in our communities. And with that, I'm going to hand it over to Melissa Polek, and she's going to give more of an epi perspective update on COVID-19.
Thank you, Kyra, and good morning. As we're moving towards this path of endemic COVID, I thought it was important just to talk about endemic, epidemic, pandemic, what they mean and how they differ from each other. So endemic refers to a constant presence or usual prevalence of disease or infectious agent in a population, and this is within a certain geographical region. This can be considered an expected baseline of illness in a population. And then we talk about epidemic, which refers to an increase, which is often sudden, in the number of cases of a disease above what is normally expected or above that baseline in the population. This is very similar to how we define outbreaks as well. The difference is in an epidemic, you're looking at a larger geographical area. An outbreak has a very much more narrow scope. And pandemic refers to an epidemic that has spread over several countries or continents, and it usually affects a large number of people, such as a global pandemic, which is what has occurred related to COVID-19. And as we shift from the pandemic to endemic phase, we expect that there will be some differences in transmission patterns with COVID-19. So for example, the pandemic surges versus endemic seasonality. So as COVID-19 moves towards endemicity, we do expect to see changes in the overall patterns of disease occurrence. For example, we've been living through surges of disease transmission that have occurred throughout the past 2 years. But as we enter into an endemic phase, we do expect to see a more seasonal pattern established, which will be similar to influenza and other respiratory diseases. Although surges will likely still occur until we reach this endemic phase, the hope is that those surges will become less disruptive to community infrastructure and our daily lives based on continued higher levels of immunity and protection within our population. And this is based upon vaccination uptake, as well as previous infection with Delta and the Omicron. So when will we see COVID-19 become endemic? There's really no light switch to endemicity. It's a process. The timing is unknown, but we do know that we are in the midst of the process. Generally, there needs to be an equilibrium or a balance between the level of transmission and the level of immunity within the population. And the increased infectiousness and the shortened incubation period of Omicron is expected to have driven an increased level of immunity within the population. And the hope is that Omicron will have served to accelerate our transition to the endemic phase. A few response changes have occurred as the COVID-19 pandemic has evolved. Our public health response has also evolved. And as we move through this process of endemicity that I've described, much of the approach is shifting from a government oversight of mitigation measures to empowering individual responsibility and risk reduction behavior decisions. An example of this is a change to disease investigation and contact tracing. Case investigation and contact tracing now focuses on outbreaks, specifically in high-risk settings, and it may no longer focus on the individual investigations within the general community. This transition is allowing public health to prioritize efforts for people and communities that are at higher risk and where we have public health interventions have the greatest opportunity to reduce morbidity and mortality. That said, local public health agencies continue to have the autonomy to deploy disease investigation and contact tracing efforts based upon the unique needs of their community. For example, targeted approaches towards those who are vulnerable to severe disease and may be eligible for therapeutics. And also the Nevada Health Response website has tools and information for the public to help navigate access to testing and treatment resources and to help people understand what to do if they do test positive or were exposed to COVID-19. And then over the course of the pandemic, testing resources and availability have changed dramatically. At the beginning of the pandemic, there was limited availability for testing and individuals needed to meet specific criteria in order to qualify. Laboratory-based molecular testing was the first available test, and it still remains the gold standard for COVID-19 testing. It's also the only testing mechanism that will allow for genomic sequencing to identify variants of concern within our population. Point-of-care antigen tests also received FDA emergency use authorization in 2020, which allowed for quicker turnaround times and increased access to testing overall. Now we have over-the-counter self-tests that are available, which is another tool for individuals to have that autonomy that we've talked about over their own health and prevention decisions. And with that, I'll turn it over to Julia Peak.
Good morning, everybody. Thank you for having us again. I think it was outlined clearly that we're in a different place now than we have been throughout the pandemic. And so I'm just going to take this very last slide just to talk through some of that. And really the posture from public health is not the crisis response that it has been, but really utilizing the tools that we've always used for public health and a specific focus on risk reduction and equity considerations, looking at data to identify which groups may be at risk for more severe disease or death, or who are not getting access to resources necessary. As was previously mentioned, we've had huge challenges with supply issues over the course of the pandemic. Initially, PPE was such a huge challenge, and then testing soon thereafter, and then vaccination soon thereafter. And so we had to give services to those at most risk, and that was a huge challenge. But some of the things I'd like to highlight on this slide is just where we are now with some of those things. So testing really, as was just mentioned, is diverse. There's a good amount of private testing available and requirements related to testing, including that in travel-related testing, worksite testing, and then personal need. You've either been exposed or you're symptomatic and you would really like to get testing to either rule in or rule out COVID. The at-home test kits have been really a huge part of the response in the last several months, I would say most specifically. As you know, the federal government has now allowed insurance to cover some at-home test kits as purchased through pharmacies or through the plan and sent directly. There's also the free federal test kit program, and I just encourage folks to go and get those 4 kits per household. It's really great to just have that available to you should your family need it. And also Nevada did a large purchase of at-home test kits, and we've positioned those at various community-based organizations, and we're looking to do another purchase of that. One of the challenges is those are a great resource that are used among all states. And when there is a high demand, like we saw with Omicron, those are purchased so incredibly quickly. And then the access at pharmacies is really reduced. So what we're trying to do is order those so that they are in place should residents need them. There's also targeted testing programs. These are primarily funded through our Epi and Lab Capacity Grant through the Centers for Disease Control and Prevention. And there's specific grants that focus on specific target populations. I've just named a few there. So those are going to continue to be a really good sentinel reporting of data because we're required to do certain interventions in those locations. The next thing, obviously, vaccination is a primary response, not only to this, but any vaccine preventable disease public health issue. We had huge supply issues, as you all are aware, right when we started getting vaccination, but now it's not the issue any longer. And so now it is just ensuring that people have the information to make informed decisions and that we're available to them to help navigate what that system looks like. For us, one of those things has been to stand up a call center because there's a variety of places you could go based on your schedule to get vaccinations. And so we'd like to continue that effort. One of the things that I'm really excited about is really over the last couple of weeks, we've stood up therapeutics programs. I've listed a few options that we're going to have within the state, but Nevada devoted over $19 million of ARPA funds to this effort, because one of the things that we saw that was really difficult throughout the pandemic, especially when therapeutics hit, was again that equity piece. And so when we were delivering this limited supply in private sector settings, there was challenges with folks navigating those. So last week we stood up both a home health option as well as a fixed site option in Clark County. This week, we're rolling out the Northern Nevada option, and then we're going to do a telehealth type visit with prescriptions for oral antivirals in our rural communities. So hoping to roll that out this week and next week. So that again is just making sure that people have access to the medications available based on their specific medical need. And so I do have to mention Dave Weist is on the call as well with Florida Pharmacy. If you have specific questions about the therapeutics that I can't answer. And again, there's a number of other risk reduction techniques that an individual can use regardless that we have shown to be effective. And that includes voluntary masking. If you can do things in an outdoor setting, birthday parties and other things, that's going to be a great option ongoing. Again, social distancing when you have the ability to do that. And I think over the last 2 years, we've been very creative in work for most of us. And if there's options to telework or have a low density work site, not just for COVID, but for GI outbreaks and for all sorts of other outbreaks that occur in a work-based setting, those can continue to be utilized. And so that's really what we're looking at now, integrating a primary, which is vaccination, secondary, which is testing and epi follow-up, and tertiary response to public health, which is the model that we use for all other diseases. So with that, we are happy to take questions that you may have.
And this is Kyra again. I do see some questions in the chat. One question.
I think this is Dr. Khan, Chair. We would like to go in the usual order. Leslie, if you could make sure that everybody has an opportunity to ask a question like we have done before.
Well, I think that we should just ask people to raise their hand if they have a question. There were some questions in the chat. The first one that I saw, we might as well start with those if that's okay, was from Commissioner Tyler Garner. She wanted to know if you have a national vaccination average.
Yes, I just looked that up, and nationally it looks like 64.7% of the population is fully vaccinated.
Great. And then we also had a question from Commissioner Winkler. He wanted to know if there was any estimate on positive cases that might not have been recorded due to the increased home testing.
Yeah, this is Kyra Morgan. For the record, I don't have a good quantifiable estimate. However, we know that there are probably a lot of cases in the community that did not present for a PCR or reportable test. In other words, you know, folks who tested positive through an at-home test, or maybe were symptomatic and had members of the family test positive but didn't feel the need to seek that testing themselves. We believe that's a significant volume, but we don't have a good way to put an exact estimate on it.
This is Julia Peak. I would just add that we have a public health surveillance system. It's called the National Drug Retail Monitoring Program. And one of the things that Nevada has done, it's an over-the-counter drug and or purchased inventory that's provided to the states. And so one of the things that we did is we worked with the University of Pittsburgh, who oversees that program, and they're integrating into that system the purchase of at-home test kits, the purchase of gloves, of masks, et cetera. So at the very, very least, in the near future, hopefully we'll be able to track at least the purchases done through a pharmacy. So it gives us a little indication of what's going on as far as at-home test kits in that market.
Anybody else with a question?
Commissioner Flo Khan had a question.
Yeah, actually, I have a couple questions. The first is, as those spikes occurred within the hospitalization setting, were you noting whether or not people were vaccinated?
Yeah, the Nevada Hospital Association maintains the data on hospitalizations. I have seen them report out on the proportion of hospitalizations that have received vaccination. What we have been told, especially in the recent Omicron surge, is that there is a nuance in that, you know, so many people, Omicron was so pervasive in the community during the surge that there were a lot of people who were presenting at the hospital for other types of emergencies or other situations. And part of their protocol would be to test individuals, and those individuals on occasion would test positive for COVID. And it wasn't a rare occurrence, according to the Hospital Association, that individuals in the hospital, you know, were there for other business, but happened to be identified as a COVID patient. And so what they have reported to us is that at one point in the Omicron surge, 43 of those reported hospitalizations had received some form of vaccination. They weren't able to quantify if those individuals were fully vaccinated or had received boosters, and they also weren't able to quantify exactly what the severity of illness was. But what they expressed to us is that they thought it was less of an instance of those individuals, seeking care for COVID-19, and more of an instance of it was just so persistent in our communities that individuals who present to the hospital also happen to have disease, and therefore they did see a significant number of vaccinated COVID patients.
Okay. Thank you for that. My second question was, have you noticed through your collection of data whether or not specific areas of the state or populations within the state where the vaccination rates are particularly low? And then are there targeted programs to outreach to those areas?
Yeah, so this is Kyra Morgan again, and I think I'll hand it over to Julia Peak for the second half of that question. We have seen over time kind of variability in vaccine hesitancy, specifically among different racial ethnic groups. Our African-American population, last time I checked, which was about a week ago, so it's probably pretty consistent, has the most, I should say the least vaccination uptick, so possibly the most hesitancy. And then we also monitor frequently, demographics of individuals who are testing positive in relation to individuals who are receiving vaccine. And we have found in general 71% of cases in the Omicron surge were of a pretty healthy age group, so adults under the age of 50, so 18 to 49-year-olds. And then in regards to race ethnicity, 71% of new cases were white, non-Hispanic, or Hispanic. However, we know that that's probably because most of Nevada's demographic population is white, non-Hispanic, and Hispanic. And so when we do that as a rate to adjust for different population densities, African-American, non-Hispanic populations are most impacted.
Yeah, Julia Peak for the record, I'll just add a couple things on that second question. So how are we identifying targeted groups to develop vaccine interventions? Kyra mentioned it really good. We have the data to provide good information. Early on in the pandemic, we also worked with the Minority Health and Equity Coalition out of UNLV, and they were able to do focus groups for us. So even before we had vaccine in the state, we had some good understanding by those focus groups of what type of messaging would be most valuable to them. So that really spoke to the racial demographic differences, but we also have great geographic differences in vaccination rates. And so one of the things that we're doing is partnering with Immunize Nevada, who's an amazing partner to us, and other community-based organizations who are really a better messenger than perhaps the state in certain regard. We're also utilizing community health workers, and so we provide them with the education and information. Ideally, they are from the community, then going back to serve the community, and so they have that information to be helpful. And it is providing them information to make an informed decision about vaccination for themselves. The other thing that we've been using is understanding when to use incentives, either financial or other motivators, if people are willing to do it and just needed an extra motivator to do that. And last but not least, one of the things that we're continuing to ask for funding for and is to support is the mobile vaccination units, because we can be really effective in that regard by standing up locations where the data is reflecting there's an increase in cases and potentially low vaccination rates as well. And that can be done not only for vaccination, but testing. So we're going to continue to invest in those mobile physical units that we can go out. Great model has been used in the past for like the mammo van or oral health services in our rural community. So we're going to continue to utilize that for COVID response and then morph that once we have the availability of those vehicles to do all sorts of public health services in the areas of need.
Thank you.
Great,
So any
thank
other questions? Because I have one, but I need everybody else to go first. Leslie, anybody else?
Nobody has their hand raised.
Okay, so I have a quick
Mason
question.
does.
Mason has his hand up.
Go ahead,
Oh,
Mason.
Sorry, Chair
Sorry,
Khan, and
Mason.
I'll be very brief, but can you hear me okay?
Yes.
No, excellent presentation, and I just wanted to say personally, as a hospital CEO of Nevada's largest public hospital, but also wear a couple of hats in the state, but as a chairman of the NHA, I just want to say thank you to our public partners, our state partners from the beginning. And I remember that phone call that night. We had the first patient in the state of Nevada, and I just want to say thank you to Director Whitley and your entire team. I've gotten to know you far closer over the last 2 years, and you have been there from the beginning, from where we had no PPE and testing and therapeutics and pharmaceuticals and treatments to all the things that we needed. So I just want to say personally thank you. Again, I've seen some of the worst, unfortunately, happen in our communities here, and what I've always noticed is that we always come back stronger, and I see the best come out of our people and our representatives. So I just want to say thank you on the behalf of UMC and NAHA. So always enjoy working with you, and we are definitely farther ahead than we've ever been. So just personal gratitude to all of you.
Thank you, Mason. So quick question from me is, as we all know, thousands of people use the rapid test at home as they became available online or otherwise. And your data obviously does not include the positive tests from those rapid tests. So when the data is released about positivity rate and daily rates, it doesn't include that. My assumption is that your positivity rate is a lot higher if all those people reported the positive tests to the state or into a system or process. Is that a correct assessment? And do we have any guesstimate how many positives were there in this home tests that didn't get reported?
Sure, this is Kyra Morgan. I could get started, and then I don't know if Melissa or Julia will have anything to add. You will notice that I didn't report on test positivity rates today in the presentation, and that's exactly why we recognize that there are gaps in our data that are largely driven by the availability of at-home self-administered tests. And so there's absolutely conversations taking place in Nevada and at a national level around, how do we evolve these metrics over time to make sure that they continue to be relevant. I don't have a good guess on magnitude of how many individuals are out there who would have tested positive on an at-home test, but I think it's a significant number. The one thing I will also add, though, is that we're not receiving negative or positive tests from that group, right? So it's not as skewed as you might think, because we're not receiving any at-home test results. And so when I look at our dashboard, which all of the data that was presented today is public facing and available to you, updated on a daily basis on the NV Health Response website. And if we look at the test positivity rate, from a statistical perspective, the pattern has been entirely indicative of the surges that we've observed in Nevada. So even though it is lacking a huge chunk of test results through those at-home self-administered tests, it is indicative. When cases are going up, test positivity goes up. When test positivity starts coming down, we see cases follow quickly thereafter. And so I do believe that statistically speaking, it's still a decent indicator of disease transmission in the community. Even though you're absolutely correct, it's becoming more and more obsolete as different testing options are available.
Thank you. Anybody else has any questions so we can move on? Hearing none, should we move on? Any other comments from anybody from the presenters? Thank you very much.
Thank you for
right.
the presentation.
Yes, thank you. So we can move on to the next item on the agenda, and that's for possible action. Discussion and recommendations of methodology, transparency, accountability, and data use strategy regarding healthcare cost growth benchmark. We have Michael Bailett from the Bailett Health. This is a follow-up, as you know. So we have allocated 90 minutes. Michael, if you are here, kindly keep in mind this 90 minutes includes questions from our commissioners. And as you will recall before, the commissioners do always have, and rightly so, a lot of questions. So I hope your presentation takes that into account in the interest of time. And I really am a stickler for time. I keep repeating myself because I have to respect everybody's time. It's a weekday and everybody has to get back to work.
Thank you, Chair Khan. I am aware of that and I will stick to the time. I want to note that I think I may have more content today than we're going to get through. And so we'll stop at the end of 90 minutes, inclusive of questions and comments from commissioners, and pick up at the next meeting wherever we end. I also want to also voice my appreciation for Kyra, Julia, and Melissa's presentation, which I thought was excellent.
Also, a quick question. What is your preference in terms of efficiency and otherwise? Would you like the commissioners to ask you questions as you are presenting or towards the end of your presentation?
So I'm going to pause and ask questions of the commissioners. And so I ask that the commissioners hold their questions until those pause points when I ask questions, because I specifically going to pause and ask for input.
Okay, perfect. Thank you.
Sure. All right, so I thought it would be helpful to identify what we're talking about today and what we're going to be talking about in upcoming meetings. Here's our, as of today, February 16th, our meeting plan. It's pretty well detailed for the next 4 months. You're going to note that while we've been focusing in recent meetings on the benchmark strategy, that we're going to begin to make time to talk about your 3 bills that you can introduce or propose to introduce for the 2023 session. And so you'll see we've got specific meetings where time will be allocated for that process, all the while continuing our work on the benchmark strategy. This plan is, as you can see, it's fairly detailed for the next 4 months. What happens June and beyond is less well defined, but we will define the planned agendas for those meetings over the next few months. So for today, we're going to wrap up our discussion of measurement and reporting of benchmark performance. We spent quite a bit of time on this at our meeting in January. I'm going to introduce the concepts of transparency and accountability. And if time allows, I'm going to introduce discussion of the data use strategy, because we are about to pivot from many meetings of talking about the benchmark methodology to talking about the broader aim of the benchmark strategy, which is to make advancements in improved affordability. So first, I'm going to give you some feedback from the advisory subcommittee. I shared with them your preliminary recommendations on benchmark performance assessment when they met most recently, and I'm going to share with you what they had to say. So they gave comment on 3 of your tentative recommendations. The first one on attribution to clinicians. You all agreed that insurers should be allowed to use their own attribution methodology, but they should be asked to disclose that methodology, and that there should also be an analysis in the future to determine whether the differences in the methodologies are substantive enough to warrant a common methodology. The advisory subcommittee agreed with all parts of your recommendation. 2, we had discussion in January about how to organize clinicians into large provider entities for the purposes of assessing performance against the benchmark. You supported the creation of a statewide provider directory to attribute individual clinicians to larger entities if feasible. And DHHS has agreed to evaluate the feasibility of this option. And in fact, since our last meeting, has organized a call with Oregon, because Oregon is pursuing this right now. The advisory subcommittee did not voice any disagreement with your planned approach. 3, you recommended applying statistical testing and specifically use of confidence intervals to determine whether a payer or a provider entity met the benchmark. They agreed with your recommendation. All right, so lots of concurrence, as you can see. All right, so next, I want to go to a topic that we began discussing last time, but we didn't reach agreement on, and then touch upon 2 last topics specific to performance benchmark measurement. So I'm going to start with impact of high-cost outliers and whether to make an adjustment to the performance benchmark methodology in response to them. Okay, we did talk about this last time. I'm going to cover some content that we covered last time just to remind you because you may not remember. So high-cost outliers are individual members of health plan or patients for a provider organization with extremely high levels of spending in a given year. This spending is real spending, and we want to include it when we're tracking state level performance and market level performance. By market, I mean commercial, Medicare, and Medicaid markets. Patients with high spend present mostly randomly in the population. You can't tell when they're going to appear. Often their spending is extremely high in one year and then drops down to much, much lower levels the following year. For many of these patients, there is not a great deal that either a health insurer or provider entity can do to dramatically reduce their level of spending. And so for that reason, I believe that it's not fair to judge an insurer, performer, or provider's performance against the benchmark when it's influenced by these randomly occurring events that really have a significant impact on year-to-year performance. Meaning, if a provider entity has 5 patients with, I'm just making this up, $2 million of spending in a given year, and then the next year has 1, that's going to have a significant impact on their trend calculation and our assessment of their performance against the benchmark. Conversely, if they go from 1 to 5, it's going to have an impact. So it's commonly the practice that when insurers and provider organizations contract on total cost of care contracts, these are ACO contracts, that they take actions to prevent a small number of members from significantly impacting the calculation of trend. And what they do is they truncate spending for those high cost outliers. I shared at the last meeting that we've heard in other states that truncation is often at $100,000 to $150,000 per year per patient for a commercial population. We heard from the advisory subcommittee that in Nevada, it's more around $75,000. But the idea is that when assessing the performance of an insurer or provider entity, you would cap the spending at that level, and everything above wouldn't be counted when you were calculating their performance against the benchmark. Okay, and why? Well, because when we're measuring performance against the benchmark, by doing the measurement and publicly reporting results, we are in fact holding insurers and provider organizations accountable to the benchmark. And so that's the reason for the truncation. It's to be fair in the assessment. And I think I just explained this last point. So Rhode Island had some experience with high cost outliers. They did not truncate initially. And what they found was that high cost outliers had a very significant impact on the performance of provider entities. There was one ACO for which high cost outliers increased their trend rate from 3% to 11%. So their performance went from being within the state's cost growth benchmark to being way above it. And it was solely due to a few high cost outliers in that particular given year. In addition, we found that in this state, that when high cost outliers had their spending truncated in total cost of care contract terms with insurers, but not in the benchmark performance, that the provider organizations couldn't make sense of the differences they were seeing in trend rates between what the insurers were telling them for their contract reconciliations and what the state was telling them. So as a result, Rhode Island began truncating high cost outliers beginning with 2020 performance data. And in fact, they are going to be reporting their results publicly next month using the new truncated methodology. So when we last met, you were leaning towards supporting truncation. but you did not have a common agreement. You also recommended you were leaning towards analysis of outlier spending to determine the causes and whether there were opportunities for slowing growth. But again, there was an agreement and we ran out of time, so we had to stop the conversation. So that's where we last were. We did share this information on truncation with the advisory subcommittee. They supported truncating high-cost outlier spending. They also supported working to understand whether there are opportunities to slow spending associated with high-cost outliers. All right, so I think that, whoops, I didn't want to go that far yet. So let me pause now, and I'd like to request your questions and feedback on whether or not you want to support truncation of high-cost outlier spending. This is solely at the payer and the provider entity level, not the market level, not the state level, and also this analysis of outlier spending to understand its causes and whether there are opportunities. Tyler and then Leanne.
So I do have a lot of, I want to make sure we definitely discuss this and hit it from all angles. One of the things I want to understand is at the state and market levels is we're able to get that aggregate data because it's just Medicaid and Medicare, things like that, or I'm failing to understand how we would get total healthcare cost if at the provider and payer level we weren't getting that information.
Oh no, Tyler, we'll be getting it at all 4 levels. The question is whether when calculating performance against the benchmark, we want to introduce truncation. And the reason that I'm suggesting not to truncate at the market and at the state level is because those populations are so large that you're going to see basically the same incidence of outliers from year to year, whereas you're not going to see it at the provider entity or payer level because the populations are smaller.
So, because I guess I don't understand then the methodology and the reporting then. If insurers can exclude high cost, how are we then getting it at the state level if it's not included in the numbers that are?
They'll provide it to us truncated, or they'll provide it to you actually. They'll provide it, or more technically, they'll provide it to Kyra. They're going to provide it at the insurer level and provider entity level with and without truncation. So you'll have the total spending. The question is, when you publicly report performance, are you going to truncate?
Got it. So, because my concern is that the board is instructed to ensure that all the data that we're reporting is publicly available and transparent. And if there is a point where insurers and providers can send in different numbers, that's not transparent. And
I mean, if you wanted to later on, you could report it with and without truncation. I'm just suggesting that for purposes of holding an entity accountable and saying they did or did not meet the benchmark, you should truncate. But if you also want to separately report without truncation to see the impact of truncation, you could do that.
Okay. Yeah, I think that was kind of the holdup for me, is I want to make sure we do have all the numbers, and I guess we could separate it out. But what? So I'll let other folks put in some questions.
Okay. Thanks, Leanne.
So just thank you to Tyler for those questions. They were mine as well. I do support truncation responsibility because we are also giving all of the details. I think when you're presenting it, Michael, and you say things like a few patients might not be included, what was missing from that statement is, but you're going to tell you how many of those is a few. Was it 1 patient? Was it 5 patients? That those details are behind these general terms of a few.
Yeah, so Leanne, we won't know the answer to that because the payers are providing the data in aggregate. So we'll know how many dollars are above the truncation point, but we won't know, is that 1 patient or is that 10 patients? Because
we'll know the dollar amount that was cut off.
Yep.
Okay, I think that's the same transparency. Okay, thank you.
Sure. Sandy, then Tiffany.
Yeah, so I just want to say thank you to the advisory subcommittee. I really appreciate their work on this, and I also support the truncation. And that's all. Thank you.
Thanks. Tiffany?
Good morning, and thank you for the discussion. I am strongly supportive of truncation, particularly because of the relationship between outliers and the ability to gauge whether or not someone met the benchmark. Outliers can skew the data from that perspective, which would impact our confidence intervals, I believe.
Right.
If I'm understanding that. And
right.
So from that perspective alone, because part of this is about how do we support folks to make progress around this, believe we really got a control for the outliers. With all of that said, I would support truncation if it's accompanied with some supplementary analysis of those outliers annually. So not a losing of that data, but some separate analysis that allows us to unpack if there are issues or things happening there that could be targeted. And so one, have a question about whether or not the committee was aware of that and is supportive of it. And two, just want to implore us to consider the truncation, particularly because of the ways in which outliers impact performance measurement.
Thank you. Flo?
I just wanted to also support the truncation. I think it's important to make it a fair assessment of what the actual costs are. So thank you.
Okay, all right. So what I'm hearing so far is support for truncation, support for complementary analysis to understand the reasons for the outliers and also whether there's an opportunity. And three, also transparency about the spending that is above the truncation point, so that that it's clear to the public. And exactly how that reporting is done, that's for another day. But those are the three messages I'm hearing. Anybody want to add anything else? Yep. Okay, good. All right, so I'm going to press us on. Thank you for that productive conversation.
So this is Dr. Khan. So my understanding is even Medicare does have a separation of outliers in their data processing and also reimbursement processes. So I think the outliers, if they are separated out, and if we still receive some of that information, that's very helpful.
Right. Okay, so our next topic is risk adjustment. This is another question around performance benchmark measurement. And I'll promise you that after we get through risk adjustment and population size, we will be done with statistics for today, or at least you're needing to wrestle with statistics. So cost growth benchmark states typically risk adjust data when calculating change in spending over time. And the reason for this is that a payer or a provider's population could conceivably change over the course of a year. And those changes could impact their spending growth to either increase it or decrease it. So clinical risk adjustment is one type of risk adjustment. And it assesses conditions that were diagnosed and treated during a performance year. And it's used to predict what spending would be. So if you have an increase in patients who all have multiple complex comorbid conditions, then your population might be judged to have become sicker over the course of the year. And this is done using pretty sophisticated software that both insurer and large provider organizations will license. It uses claim data and reads diagnoses and procedures, mostly diagnoses off of those claims. The best risk adjustment models can explain about half of the variation in healthcare spending, and with truncation, even a little more than that. When risk adjustment is performed, it's performed only at the insurer and provider level. So this is similar to what we just talked about for truncation. And again, the rationale is the same, that at the state or market level, the amount of change that you're going to see in a population year over year is going to be very small. Maybe over a decade or two larger, but in an individual year, not so much. And so other states have focused on risk adjustment at the insurer and provider entity level. So one of the complicating factors in clinical risk adjustment is the impact of coding completeness. So the health status of a full population is generally pretty stable between consecutive years. While we, for example, might have an aging population as a nation, over the course of 1 year, the impact of aging is going to be pretty small and isn't going to have much impact on the health status of the population. However, clinical risk scores using the type of software that I just described can record significant increases year over year because of improved documentation of diagnoses on claims. So the population health status doesn't change a lot, but the clinical risk scores suggest that the population health status did change a lot. So we've got some information on this from a couple of states that implemented cost growth benchmarks earlier. Massachusetts, which implemented their cost growth benchmark in 2013, has seen increases in clinical risk scores every single year, amounting to almost 12% between 2013 and 2018. They've done analysis to try to corroborate that increase, and they have not been able to find compelling evidence that, in fact, the population has become sicker. So their health policy commission, which is roughly the equivalent to this commission, their staff is now recommending that payer and provider performance be based on growth with unadjusted spending in the future, because they believe that the clinical risk adjustment that they have been applying creates a great distortion in performance assessment. I've got information from another state that gives a little more insight. So in Rhode Island, they use clinical risk scores their first year, and the risk scores grew almost 5% from 2018 to 2019. The impact that this had on their cost growth target is it effectively doubled their cost growth target from 3.2% to 6.4%. That means that any provider organization or insurer that had trend that was at 6.4% or below would meet the cost growth target because of the impact of the clinical risk adjustment. So this really was significantly undermining their whole cost growth benchmark strategy, which and they call it a cost growth target, not a benchmark, just so you know. And so recognizing that this was compromising the integrity of their program, they made a decision to only risk adjust using age and sex variables, starting with the 2020 performance year. And in fact, those are the results that they're going to report next month. Washington, a couple months ago, decided to do the same thing, age and sex. So Massachusetts said, we're not doing any adjustment. Rhode Island and Washington now have made the decision to adjust using age and sex and not clinical risk adjustment. Here's a recent paper in Health Affairs, big health policy journal from December. They looked at the difference between self-reported health status using a patient survey, the CAP survey, and they compared it to risk scores that appeared on claims using a clinical risk adjustment program, one that the federal government uses, HCCs. And you can see they concluded that, or they suggested that coding may account for most of the observed risk score for ACO beneficiaries. And this was, I think, in the Medicare program. So this is just another indication that coding coding practices create rising risk scores that may not accurately reflect what's going on in the population. So I want to share 3 options for you and then open up for a discussion. And you can both ask questions and then respond to these 3 options. So the first option is to adjust spending at the payer and provider organization level by normalizing their clinical risk scores. So by normalization, what we're doing is we'll say, okay, so everybody's risk scores went up. The average increase was, let's say, 2%. So we're going to normalize 2%. And if a risk score grew by more than 2%, then we are going to, let's say it grew by 3%, then we're going to subtract 2 from 3, and we're going to say we're going to make a 1% adjustment. Conversely, if a provider organization's risk score grew 1%, but statewide it was 2%, then we're going to say the population actually got healthier by 1%. Okay, that's normalization. Insurers can do that normalization at the provider entity level, but the only way to do it at the insurer level is by using an all-payer claims database to do the analysis. And as you are all aware, Nevada does not yet have an all-payer claims database. So normalization right now is feasible in Nevada only at the provider entity level. The other thing I'll note about normalization is it doesn't remove the incentive to increase coding completeness. So this is option number 1. Option number 2, this is the Rhode Island, Washington method, use age sex factors. So here you would look at changes in the age and sex of the population year over year. Those changes are going to be pretty minor. I mean, unless something odd goes on, let's say a large employer with a younger or very older workforce leaves the state, that might have an impact, overnight. But aside from that, you're going to see pretty minor changes using age and sex factors. This would not capture more substantive changes in the health status of a population, though, because we know that age and sex explains much less variation in spending than clinical considerations. But this does remove the overcompensation that clinical risk scores create, as I indicated from that Rhode Island example. And then the third option is do what Massachusetts has proposed to do. And because clinical risk scores overcompensate for changes, population health status, make no adjustment based on the assumption that in a 1-year time period, you're simply not going to see a lot of change in the health status of an insurer or provider entity's population. All right. So those are the 3 options that we've identified. And so I want to share with you that we asked the advisory subcommittee about these 3 options. Some of them liked option 1, normalization. 1 likes 2, using age and sex. And some of them asked for more time to digest this because this is complicated. So I want to pause now and ask you which of the 3 you prefer. I recognize that this is complex and you might have questions, so feel free to ask those before you weigh in. Tiffany?
Thank you. I have a clarifying question. Given the fact that the risk adjustment is to account for changes in overall population health, what is the implication of any of these approaches as we're going through a pandemic? Shouldn't we expect some type of increase? And if so, then the first approach, where you're accounting for what is generally happening for everyone and adjusting up and down, might be the more appropriate approach, but I'm not sure. Can you talk a little bit about what you would anticipate as implications?
Yeah, well, there's a bigger question. Yeah, there's a bigger question here, which is what do you do about measuring change in spending during the pandemic? We are working with other states that are about to report out their results for 2020. And trend in 2020 in other states was negative. Okay, negative. And that's because for at least 2 months, people stopped going to the healthcare system altogether. I mean, utilization dropped to 0, and then it never came up to baseline. In fact, it still didn't return to baseline in 2021. So I think that certainly for 2020 and 2021, we're going to have to contextualize the trend. I think this is a much bigger issue than risk adjustment. We're just going to have to say these are aberrant years, and hopefully we're going to go back to something a little bit more normal, where we're not going to see dramatic swings in utilization. Tyler?
Well, thank you. Just to clarify, this would this be like what we were talking about before for truncating high-risk outliers, that we would receive basically separate data sets, just everything, and then another risk adjusted?
No, it's a little different here. So people would give us the payers would give us full spending. And depending upon the approach we take, they would give us either a risk score, or they would give us data so that we could calculate a risk score. So it depends on which of the options we take, but the dollars that come in are the naked dollars. The adjustment is applied to the aggregate spending after you roll up all the dollars.
Right. And so I guess some issues there would be normalization of what their risk scores are if we were trying to get to the clinical risk side.
Yeah, so again, normalization, the insurers can do at the provider level. They can't do it to themselves, obviously. Yeah. So what they could do is they could say our overall risk score went, as I said before, went up 2%. And then they could tell the state, and here's how much it went up for each of the large provider entities that we're reporting on. And then the state could normalize.
Okay. I had just when we're talking about Rhode Island, don't they have a service cap law?
Yep, they do, for hospital prices.
So does that play into any of the kind of info we're getting about their cost growth target?
No, I mean, it makes it easier for them to achieve it in the commercial market, but that's it.
Okay, thank you.
Sure. Dan?
Yes, so I have a request, if we could get the link to that Health Affairs article, either in the chat, or Leslie could send it to commissioners after this meeting. I've seen it, and I recommend others take a look at it. And my support would be for making no adjustment for changing population.
Okay. Tyler, did you re-raise your hand, or is that from before?
I did, because I did read the report. And kind of my issue with it is it's evaluating what is actually coded and diagnosed versus what people self-report on a survey. So I'm not sure how much we can take from that. And I guess I would also like to make my preference known to make no adjustment.
Okay, thanks. Sandy?
I agree. Recommend.
I'm sorry, your volume dropped out, Sandy.
Can you hear me now?
Yeah.
Okay, I recommend no adjustment as well.
Okay, thanks. Linetra?
I agree. I agree with making no adjustment.
Okay. Anybody else want to weigh in? All right, you reached consensus there, or agreement there, faster than I would have predicted. Thanks. Okay, so the very last topic on benchmark reporting methodology is determining what's a sufficient population size. So there are two questions here. And by the way, I want to note that the presentation that Sandy sent out in advance of the meeting is slightly different than the one I'm presenting today, and we will share the one I'm presenting today subsequently. So 2 questions. How many lives must a payer have to report their total healthcare expenditures to the state? And how many lives must a provider entity have, or patients, in a line of business for its performance to be publicly reported? So here's what the other states have done. I'm going to start with payer reporting. Delaware and Rhode Island, small states, not a lot of insurers. They just identified the largest insurers in the state, which was easy for them to do. And they said these are the ones. In Connecticut, they have a larger insurance market. So they picked the commercial and Medicare Advantage insurers covering about 85% of the lives in the state. In Massachusetts, they set a really low threshold, 3,600 attributed lives, which is, that's just a tiny amount. And Oregon, even lower, 1,000 covered lives across all lines of business. So in Oregon, basically, they're requiring pretty much every insurer that's licensed in the state to report. Okay, in terms of thresholds for public reporting of provider performance, they differ again. Delaware and Rhode Island both picked different thresholds for commercial and Medicaid and for Medicare, 10,000, 5,000. Connecticut has not yet established their thresholds. Massachusetts hasn't published any. So I don't know if this means they don't have any, but they are internally held. And in Oregon, it's 10,000 attributed lives across all markets. So that's combined Medicare, Medicaid, commercial. So Oregon clearly is trying to gather as much data as possible and report as much data as possible. Okay. So these are the two questions that I want to put before you. A little bit on sufficient population sizes. This becomes a little less pressing now that we've adopted confidence intervals, because we'll be able to tell what's whether or not an entity met the benchmark. Oregon and Connecticut are collecting pre-benchmark data to shed light on population sizes at which confidence intervals become so large that you can't even determine whether someone met the benchmark. And this is at the provider level. So for now, what we'd like to recommend is that you require all Medicaid MCOs to report, and all carriers in the commercial or Medicare Advantage market to report at 5, if they have market share at 5% or higher. There actually are not very many insurers that meet this threshold using data that we've looked at for the state. And we recommend deferring on the provider entity thresholds for public reporting of provider performance until Oregon and Connecticut have finished their pre-benchmark or baseline analyses. And we have some sense of at what point are the confidence intervals so wide that you can't make a determination. All right. So those are the two recommendations. We put them before the advisory subcommittee. They were leaning towards supporting the draft recommendations. So just so you know, with that 5% rule, there are only 1, 2, 3, 4 payers that are above the 5% rule. Okay, because the market's pretty concentrated, as you can see here. They did raise a question about whether to include Aetna and Cigna. They are 2 of the 4 large national commercial carriers, Anthem and United Healthcare being the other 2. And when we looked at market share, we could only look at it for fully insured because the self-insured lives were unknown to us. But they thought that the self-insured lives were Aetna and Cigna, which largely serve self-insured employers, might be large enough to warrant their inclusion. Right, so they didn't recommend it, but they suggested consideration of that. So my question for you is, do you support the recommendation to require reporting by all Medicaid managed care organizations and by commercial and Medicare Advantage carriers with a market share of 5% or higher, with or without Aetna and Cigna? You can weigh in on that. And then 2, do you agree with the recommendation to defer on setting the thresholds for publicly reporting provider performance until we have data from Oregon and Connecticut.
Any comments from commissioners? Go ahead.
Sorry, did you call my name?
Yeah, I called.
Okay, so, Tyler Winkler. I apologize, it's kind of out of place, but when we were talking the last meeting about attribution, what is the fail-safe for when like a large provider entity only has like specialists, no primary care physicians? Did we discuss that at all?
Yeah, Tyler, they're not measured. We're
Okay.
only attributing based on primary care.
Got it. Okay, so just making sure I understood that correctly. I think definitely I'd support that the managed care organizations, we get their information just because it makes a lot of sense. We already have that kind of relationship with them. And I would like to see more for states that are a little bit ahead of us, so that we could get a better idea before we commit to something that maybe wouldn't be helpful. On that same point, is there any interest in maybe meeting with one of these states, kind of seeing where they're at, especially Oregon that's ahead of us doing the same kind of work, or maybe Massachusetts that has a lot of time? I can maybe just kind of put a pin in that.
Yeah, we could invite another state to come and speak before you and talk about their experience.
Great, thank you.
Sure. Leanne?
I have a quick comment or question. You said with or without Aetna, Cigna. Why would it be without them?
Well, we don't really know how many covered lives Aetna and Cigna have because it's in the self-insured market, and so they don't report to the state. So my personal feeling is, based on what we heard from the advisory subcommittee, if Aetna and Cigna are suspected of doing a fair amount of business in the state, it would probably make sense for at least the baseline analysis to ask them to submit data. And then if we find out that their covered lives are quite small, then exclude them in the future.
Yeah, my view is, I think I agree with you. We should ask them for the information to at least determine the percentage of population they have, and determine if they are within that 5% range, then they should be submitting their data. Also, my understanding is Aetna more than likely has 5% or more. Cigna, I'm not so sure.
Okay. Thank you. Leanne?
Thanks. So I'll take the second bullet first. So gratitude to Oregon, Connecticut for doing this first. And like, I agree with waiting to see what their confidence benchmarks show that we can then have this discussion further. But for the first point, I think there's a unique situation here in Nevada where our population is so skewed. So the market might be the state, but if you look at the state without Clark County, I think we're going to miss a lot of covered lives and a lot of healthcare spending activity because the population is so skewed to Clark County. So I wonder if our threshold shouldn't be 5% for the state, but 5% for a county. Because otherwise, Washoe is so different economically and other ways from Clark County.
Yeah, well, probably wouldn't want to do it for every county, Leanne, because you got too many rural counties where the numbers would be minuscule, right? But I can understand that it might be, I mean, I don't even know if the insurance department can do this, but it might be interesting to see what market share looks like if you remove Clark County. Yeah,
yes, exactly. And then along those lines, if there are large enough self-insured entities that it is more than 5% of either the state or Washoe County, that maybe they should be included because they have so much pull within a very concentrated population in our state.
Mm-hmm. Okay, I've never seen in any state anyone other than a national carrier that's got enough self-insured that's reason that they're going to meet a threshold. The standalone TPAs just never have enough volume to meet a threshold like that. All right, so I hear you supporting inclusion of Aetna and Cigna for at least the baseline measurement. Is that right?
Yes.
Yeah, okay, all right. Tony, you were fooling me with that alternative name, but I figured out who you are.
Sorry, Michael, no problem. I just wanted to, for the record, I am conflicted in this conversation and will not be participating. I'm the president and CEO of Renown Health. Hometown Health is a wholly owned subsidiary of Renown Health, so I just wanted to acknowledge for the record that I'm conflicted.
Okay, thank you for that, Tony. Andy.
Yeah, I just wanted to, I support the recommendation as it's written here, but I also wanted to just highlight that in our all payer claims database bill, it does have an exclusion for carriers that have less than 1,000 lives. So I don't know if that's relevant here, but at some point when we do have an APCD, we should be in alignment there, I would think.
Yeah, so that's probably below our 5% threshold, 1,000 lives.
Okay, good.
And I just want to clarify, you're supportive of including Aetna and Cigna for the baseline to see how big they are? Yeah. Okay. All right. So it sounds like we've got concurrence here. Oh, another hand up. Babette. Welcome.
Hi, sorry to be late to the meeting. Appreciate it. I wanted to just add, I support the recommendation as well, but is there a way for us to, I miss so much the conversation. Tell me if I'm going backwards. Is there a way for us to go find out who would be lost if we don't go below 5%? I do want to include Aetna and Cigna, but are there others? Is there an organized way to look at who the others might be?
So we do have information on covered lives for insured covered lives, just not for self-insured covered lives. So we could tell you who are the carriers that have insured covered lives, commercial or Medicare Advantage, or maybe just commercial, I can't remember, that are below the 5%, if you want that. It's a pretty steep drop off. I mean, after the 5%, they were really small.
That'd be great to see though, if you got it.
Okay.
If you got it, that'd be great.
Yep.
Thank you.
Mm-hmm.
Anyone else? We can move along. If not, let's proceed.
Okay, I think we should be able to cover transparency and accountability. We might have to defer on data use strategy until the next meeting. So these are our two last concepts relating to the benchmark. The first is about how do we make performance against the benchmark transparent? And I'm going to talk about both public reporting and public hearings. And then we're going to talk about accountability, which is what happens when a payer or provider entity fails to remain at or below the cost with benchmark. And there, I'm largely going to be sharing with you what other states do, because I want to note that the executive order specifically does not call for accountability. It does, though, call for an annual report to go to the governor. So it does have a transparency element. And what I'm going to ask you is, do you think there should be any other transparency elements? So as a reminder, this is our logic model that we're working with for the benchmark strategy. We've been focusing really just up here on how to define and how to measure performance against cost with benchmark. We have not been moving around the circle to the other elements of the strategy. We are about to begin to do so, though. Okay, but all of our meetings have been up here with this mustard colored scale. All right, so transparency is about, in part, reporting performance against the benchmark. So one way to do this is to create public-facing reports, and I'll say other communication vehicles to inform audiences about performance against the benchmark. These can be static or interactive. There might be supplemental materials like chart packs. The Massachusetts Health Policy Commission has taken this to the highest level of art. They put out all sorts of communication, some very concise. They do lots of tweeting and use of other social media. so there are a variety of vehicles, but the idea here is to push out information regarding benchmark performance so that it's transparent, visible, and ideally serves as an impetus for actions that will improve affordability. All right. So range of potential strategies. It does require some investment of state resources, though, to make this happen. And there are a lot of states that that just don't do this, that don't even have a communication strategy. Second type of transparency is public hearings. And there are some related concepts that I'll talk about, but let's start with public hearings because this is the biggest of the approaches. You could make a recommendation to conduct annual hearings. So this is what the Massachusetts Health Policy Commission does. And they can be used to not only talk about benchmark performance, but also to share complementary analysis of what's driving spending, to open up conversation among stakeholders about opportunities and challenges to improve care and reduce spending growth, and to introduce policy recommendations for slowing spending growth. Massachusetts does this in a big way. They do a 2-day public hearing after they put out their report. They do this with the Attorney General's office and with their health data agency, the Center for Health Information Analysis. They request pre-filed testimony. They have testimony from executive and legislative branches. They put together panels of healthcare industry executives who are questioned by members of their commission. And there's an opportunity for public comment. The meetings are live streamed in their entirety. They are a big deal. Now, I'll note that there are states that do this type of thing, but on a smaller scale. In Connecticut, they've taken to doing annual half-day, they call them public forums. And in Rhode Island, they do half-day meetings that they just call public meetings. So not quite as big as what Massachusetts does. I will share that Oregon does plan to replicate what Massachusetts has done, and beginning this year, they are going to kick off public hearings for the first time. I don't know they're going to be identical to the way that Massachusetts does them, but they are calling them hearings. And they are going to be, I think, more formally constructed than the public forum in Connecticut and the public meeting in Rhode Island. So my questions for you, and you can see there are multiple questions, is do you have any recommendations on processes for reporting cost growth benchmark performance? And there are a couple of related questions here that I'm not going to read. And then should there be annual formal hearings or public meetings or some other forum to talk about the results and to talk about other data analyses, complementary analyses, and to talk about strategies for cost growth mitigation? So these are less pointed questions than what I've shared with you earlier today, but I'd be interested in hearing your thoughts. Dan?
So if the Massachusetts public hearings were live streams, are there recordings that we can watch on YouTube?
You can. Yeah, I mean, they put everything on YouTube. They are a PR machine. It's amazing how much they put out.
I'd like those links. I'd like to give them a watch.
Yeah, just go to Massachusetts Health Policy Commission. They're about to introduce a new website because the current one is a little clunky. But you can find recordings of their annual hearings. They're about to have actually their 2022 hearings because they take place, I think, in March every year.
Oh, we should have a commissioner's field trip and all attend and watch in the background.
Yeah, well, you know, Oregon, before they set their cost growth benchmark, even before they started the process, they had state staff fly out 2 years in a row to sit in the audience in person to watch the hearings. They are something to behold. And it depends over time, but sometimes they're a little bit more dramatic to watch and sometimes a little less so, but they're interesting.
Great, thank you.
Sure.
Thank you for the link in the chat.
Yeah, do you have any recommendations regarding public reporting or hearings, public meetings, anything of the sort?
Right, so from my perspective as a patient advocate, right, whatever makes it easy for the population to access the data that we find is where my focus would be. And so if public hearings, public reports is the way to get people in Nevada to pay attention to what our findings are, then that's where my instinct is. But I think it'll be helpful to watch what's happened in Massachusetts.
Okay, great. Tyler, then Tony, then Sandy.
So I also agree. This whatever methods and processes that we can implement and make use of to do to get the information out there, I'd support. A lot of that I think kind of there's what's available to us. I think maybe we have to figure that out, but I think we'd all agree we'd want what's the most transparent, what's publicly helpful. I think the only thing here that I could maybe put like a definite recommendation or thought on would be if entities should be, if we should say entities met or exceeded versus the actual rate of cost growth. I think I would lean towards reporting the actual rate of cost growth just for that transparency. And then if I do think it would provide the entity an opportunity to justify or to see how much above or below they are versus just a pass or fail.
Mm-hmm. Okay, thanks, Tyler. Tony?
Yeah, I would agree with both Commissioners Winkler and McAllister. I think that it goes without saying, I think, Michael, that you have to assure that the data integrity, the rigor of the analysis, all of those things up front are appropriately done, vetted, reliable, valid, right? But once you check the box on that, go forward and let's get the detailed data out, the actual rate of cost growth, be transparent about it, hold whatever hearings, let's let the public know how to weigh in. And I think that there's a unique opportunity, if we're really being consumer focused here, that goes beyond the sharing of the data to the education of the consumer about what it means and so that they can start to advocate for themselves in terms of what might be available and how they should go about forming opinions about their own health and healthcare. Consumerism is a very broad topic. We're only looking at segments of it here. I want to be able to use the work that we're doing, the great work that we're doing here, as a way of informing so that people can learn how to advocate for themselves. I think that'd be important. So open it up, have conversations, day-long hearings. I think I'll let the details be worked out later, but I'd be advocating for transparency in process.
Mm-hmm. Okay, thank you, Tony. Sandy?
Yeah, I agree. I would be concerned about a full-blown media campaign with 2-day-long hearings in Nevada. I'm just not sure how we would support that, but I think there should be a process that's very transparent and public. So I would support publishing and hearings, but at a scaled down to Nevada appropriateness.
Sure. I get that. Anybody else? Okay, so the last topic is accountability. And as I said, I'm sharing this with you just for informational reasons because the executive order does not speak to accountability beyond public reporting and transparency. Okay, but this is just so you're aware of what's going on in some other states. So right now, there are 2 states that have created consequences beyond public reporting for exceeding the cost growth benchmark. One action is performance improvement plans, and Massachusetts and Oregon have this requirement. And then Oregon also has financial penalties. So let me share a little bit about this. So this is Massachusetts path. They have a multi-stepped path from setting their benchmark, collecting data. It's analyzed by their data agency. It goes to the commission. Commission decides whether to require a performance improvement plan. It's got to be voted on by the board of their commission, and then the performance improvement plan is implemented. Prior to this year, going back to 2013, Massachusetts had never required a performance improvement plan, which caused many people, both inside and outside of Massachusetts, to raise their eyebrows, because that seemed rather odd. But that changed just a few weeks ago. So for the first time ever, and this has garnered national attention, the Health Policy Commission required a performance improvement plan, and they required it of the largest, most expensive health system in the state, which over the last year has changed its name to Mass General Brigham. And you can see here the press release from the Health Policy Commission. I mean, just today I got an email message from Health Affairs with lots of information about this. So it's garnered lots of attention. I've included here a couple of quotes from the Health Policy Commission. The obligation for Mass General Brigham is they have to submit a performance improvement plan within a certain time period. I forget how many days. And they have to detail all the steps that they're going to take to reduce their spending growth. I'll also note, Babette.
So to me, that's kind of the reason to do the rest, right? But since it's not in the executive order, it seems to me I have a concern about legislation, because I don't believe legislation would be able to inflict or collect or even suggest penalties without a 2/3 vote in the legislature, and that's not where we are right now. So I don't know, is there a world where any executive order from the governor would be amended to include penalties? Is one question.
Yeah, so I just know there's no penalty here. This is,
okay.
This is just a requirement to submit a performance improvement plan.
Okay.
I think that there's a fine if they don't, but this is not a penalty.
Well, it's a fine if they don't, I guess is where I got a little stuck. But I think that the rest, I think if, my question is, would the executive order need to be altered and amended? And then we should talk about that, because I don't want to go beyond our scope of what the governor expected.
Yeah.
But I do believe that we should do as much as we can to get light into, the light of day into this stuff. So if we can do it, I would support that we would do it.
Yeah, well, and maybe it's something that, the governor or the legislature might want to do in the future. I mean, you are a couple years away from having, more than a couple years away from having data for the first year, right? Because it just became effective for 2022, which means that you're not reporting probably until early 2024.
Okay.
You'll report on your baseline. So you're at least 2 years away before you have your first performance against the benchmark. So maybe in the future, there'll be, some interest in doing something like this. For right now, I'm just sharing so that you're aware of what other states are doing. And it's not all other states, right? So right now, there's nothing like this in Washington, Rhode Island, Connecticut, Delaware. So I don't want to give a false impression that every other state's doing this. They're mostly doing what you're doing, which is leaning on transparency at the outset.
Okay, thank you.
Okay.
Michael, I just have a question. This is Flo.
Yeah.
In terms of their improvement or their performance improvement plan, are they working with, is the state coming in and telling them where they have to make changes, or are they just kind of given to themselves to say, you just need to get under the benchmark, you go in, you decide kind of how you want to address your cost within your own system, and then you go in and you identify and then present a plan to the state on how you're going to meet that?
That's what it is, Flo.
Okay, thank you.
So, and this This action by the Health Policy Commission in Massachusetts was prompted by the fact that for several years, Massachusetts was on average coming in at its benchmark. But the last 2 years, it's exceeded the benchmark and by quite a bit. So I think the Health Policy Commission is becoming more aggressive for that reason. I think that actually Mass General Brigham had been above for some time, but because the state overall was coming in at or below, they were leaving it be. But now that they've been above, they not only have taken this action, but as you'll see on the next slide, they're recommending additional steps. So this is from their annual cost trends report from September. The link is down here if you want to take a look at it. And they recommended 5 areas of focus, which you see at the top of the slide. But one of them, this second bullet, is to create financial penalties for above benchmark spending or non-compliance. Right now, they have fines for not complying with performance improvement plans. There are no financial penalties for above benchmark spending. They are recommending that for the first time. And I think it's because they've failed to hit their benchmark. All right, so a little information from Oregon. They passed legislation last May that authorized 2 accountability tools, performance improvement plan modeled off Massachusetts, but separate, a financial penalty on any payer provider that exceeds their benchmark without reasonable cause. Okay, that's an important phrase, in 3 out of 5 calendar years. Okay, or for not participating in the program, meaning no performance improvement plan responsiveness. So 2 things I want to take away here. It has to be without reasonable cause. So how's reasonable cause defined? Well, there's some language that the state created with its advisory body, the Oregon equivalent to this commission, that creates some, I would say, parameters, but not criteria. So they remain qualitative, but at least they've got some definition of what's reasonable. So if, for example, they had high trend in 2021, but it was because of depressed trend in 2020 because of COVID, they would consider that to be a reasonable cause, I'm pretty sure. Okay, and it's not every year, but you have to exceed it 3 out of 5 years. So 3 out of 5 years, though, means you've got to go at least 3 years before you're going to invoke the penalty, and as many as 5 years. So, you know, this is really for sustained performance that doesn't hit their benchmark, and is not going to play out for, you know, several years, obviously.
Michael, I have another question on that. Just thinking, so in terms of kind of looking at that, if they could show their quality of care improved, so maybe they spent more in a given year, but they can show that their quality of care improved. People were having more access to care. They were actually getting in for treatments and that kind of stuff. So it's not just a denial of care to reduce your costs, but they were actually improving care. How is that integrated into all of this? Because we talked earlier about it's not just access, but it's also quality.
Right. Yeah, it's a good question. Well, and it goes back to points that Tony's made in the past at some of the meetings. You know, Flo, it's been over a year since I worked with Oregon on its criteria to define reasonable cause, and I honestly don't remember if that's part of them. So I don't know. I just don't remember.
So this is Dr. Khan. I think that's a very important issue and point to keep in mind. Quality of care comes with a price. To give you an example, if a managed care organization is expecting the providers, say for example, congestive heart failure, to follow through outpatient calls, outpatient monitoring, requires extra staffing to call the patient on a regular basis, see how she is doing to avoid a readmission to the hospital. That comes with a price, and on and on and on. Similar situation with other medical diagnoses that adds to the cost to monitor quality. The provider himself, if he or she is expected to do this, to make calls, he or she has to then hire extra personnel in the office, and thereby increasing the cost of delivery of service for the provider, in this case, a physician. So unless we keep that in mind, or it is incorporated somehow in the process where managed care organizations are investing in getting better quality outcomes, then that is crucial.
Babette?
Maybe what we should do, thank you, Dr. Khan, maybe what we should do is figure out a way to talk about quality in an upcoming meeting, more specifically about quality in a PPC meeting. I think that would be good. And the hospitalists are a good example. But I also think that this healthcare, to me, has not been a world where you get what you pay for. Healthcare, to me, is not only the accountable care organizations or as you said, Dr. Khan, the managed care organization's responsibility. I think that we look at it through a prism of, we're already paying for it. We're already paying to get quality. Why are we not getting quality? So I think it's a bigger conversation than just if you provide good quality, it's because you had to pay for it. Sometimes you pay for it and don't get it. So I think that we got to look at the whole picture here, and I'm not exactly sure how to do that. I think if there's a way to have create an agenda around what are the key points that do impact quality and quality in Nevada compared to other states, I just think it's really helpful. And I'd love any support on figuring that out.
There are some
100% with Babette. It's a two-way street, no question about it. If you're investing in quality measures and you're not getting that quality, then that needs a deep dive to evaluate whether it's the provider system, whether it's the non-compliant patient system, and where are the processes and programs for non-compliant patients versus non-compliant providers who are not putting in the time and effort to do their job. I'll give you an example. If a physician, primary care physician, is spending 10 minutes with a patient in a hurry of a busy office, you won't get quality because he or she is not investing time in properly reviewing all the challenges the patient's facing or the needs of the patient as an outpatient and address those needs in a meaningful way. So yes, I agree with Babette on what she said. So it's not as simple as it sounds. That's why we need to really look at it very closely.
There are a few states that have elevated quality in a couple different ways so that it is a complement for their cost growth benchmark. Obviously, that's not defined in the executive order, but if it's something that you all want to consider, we can share information with you at an upcoming meeting so that you can think about it. Would that be helpful, Babette and Chair Khan?
Yeah, I don't want to interrupt again because I see Commissioner Winkler has his hands up, but I'd love to go again after everyone else gets to go.
Okay. Tyler.
So I think the HPC's recent performance improvement plan would be really illustrative of what we're talking about here, because they do get into those quality of care metrics, and specifically with Mass General, they say they provide quality care, but so do all these other Massachusetts providers, and they don't cost as much. So they do have those measures there to look at. So I think definitely that's something to look into.
Yeah.
So thank you for sharing with us what other states are doing. I think from my perspective, it's a little premature to talk about solutions to a problem we don't understand yet. So, but I'm glad you're sharing this information, and it needs to be a part of the conversation. But as for talking about quality of care, if we could make part of that conversation patient ratios, so for nursing, for doctors, how many patients they can see a session a day, take care of on a floor, I would like that information to be part of the conversation.
Okay, thanks. And Babette, you want to come back?
Thank you. Yeah, I think that's all helpful, particularly for us in the facility setting, because that's when a lot of the outcomes really matter, you know. not to belittle the physician at all, but I think a lot of our focus is on facility-driven quality, and something one of the other commissioners just said. What are you paying for? Are you getting good quality? You're paying the same dollars across facilities and you're getting different quality in them, then it's not a money issue, it's something else. And it would be nice to have a way to look at that. I don't know that it needs to be tied to the benchmark, but I think it should be specifically a commissioner of QPC, section of our work.
Okay, thanks.
So
Tony.
a quick so is there somebody else? Go ahead.
Yeah,
Somebody
thank you,
else?
Chair Khan. This is Tony. Just understanding, Michael, how others have accounted for, I'll say, an even broader system of care as they go through the work. So let me use the example. In communities, for example, where there's a lack of public health attention to issues like homelessness, social determinants of health, those kinds of things, and people inordinately use expensive resources like the emergency department because there's been a failure at the state level to invest in, from a public health perspective, to invest in those communities. How does that get adjudicated in the benchmarking performance levels?
So remember, the benchmark performance is looking at change over time. And so it doesn't really assess sort of the baseline utilization, price, overall spending going on within a community. It's really focusing on just how much is it changing from year A to year B. So I provide that as a reminder, and then I'll answer you more directly. It doesn't at all.
Mm-hmm. That's actually my concern. Right, so to the extent data just released today, where Nevada spends about $59 per person on public health interventions, as compared to $129 per person in other communities like New York, New Hampshire, et cetera. When you're confronted with challenges in the ecosystem, like we're going through with COVID, where health systems and others have had to take up the gap of the public health infrastructure, that drives the cost up, which is why I've always concerned about how we're benchmarking in the last 2 years for this work and how it gets counted. I don't care that we benchmark, I care that we appropriately integrate the counting where there's been a lack of infrastructure investment from other areas that would have kept people out of the settings where it costs a lot of money. Dr. Khan's point about doctor's offices and hospitals and emergency rooms, no one would argue with the fact that we need to drive to lower settings of care. But it may be a failure of the community-based infrastructure more than the fact that I can't turn people away when they show up in my emergency room. That's the law. But there's a lack of community resources to care for them and they have nowhere else to go. That's the reality. And it harms access and it hurts people's lives.
I don't think any of us would disagree.
So quick follow-up, not to belabor the point on developing benchmarks. So Bobette brought up the point of in-facility services and outpatient services. So I'll give you an example of in-facility services by providers, for example, the physicians. Those benchmarks can be developed. Some do exist nationally, and some have been put in place by Medicare. The question is, I know we are not going into accountability, but these things can be reportable and data collected, say, over a period of 1 year. Say, for example, a hospital is not supposed to see more than 15 to 18 patients per doctor. But if you see the situation on ground, they're carrying a load of 25, 26, 28, 30, and 40 patients per doctor. I'm not just making it up. I see it on the ground on a daily basis. So there has to be a benchmark and reporting in some form about how these providers are carrying. That immediately affects quality. How can anybody see 30 patients in a day and do justice to that patient's care and coordination of care as the primary care? So that's number one. The other issue is, for example, Medicare requires certain parameters like patient satisfaction, et cetera, that is collected and data is prepared, and the hospitals do keep track of that. The irony is the hospitals are supposed to report that. In my view, the physician has to be held accountable in terms of getting patient satisfaction, because he or she is the one who sees the patient and gets the comfort level of the patient in the physician. So quality benchmarks for the hospital providers is a crucial point in my view, because that's where the bulk of the care that is being compromised after discharge. For example, a patient is being discharged. If the provider or the hospitalist does not put his or her arms around the patient's safe discharge into an environment, call up the physician, outpatient, et cetera, all these things take time to put it together. And they have no time if they're carrying even 25 patients on a given day. And of those 25 patients, 6 or 7 may be new patients, which are supposed to take half an hour, 45 minutes to spend time with a new patient, and yet their shift is over at 5 p.m. or 6 p.m. and they are gone. So I don't want to go into the minutiae of it. What I'm trying to say is some reportable process has to be brought in for future, hopefully, accountability at some point for these situations once the data keeps coming.
We can make plans to share with you what other states are doing on quality benchmarks, because there are.
That would be very helpful. Yes.
Okay, Babette, and then I am cognizant that our time is almost up.
Okay, I would like to make a formal presentation that we gather what quality indicators are now reported in the state of Nevada, and to your point, bump them up against, Michael, you bringing what happens in other states. We have some quality measures in Nevada. So then we could add Dr. Khan's suggestions about what quality measures are also being used in the facilities themselves. I think what we're gonna need, if we gather all that stuff, is time to figure out, to Dr. Sloanim's point, if the whole community is suffering, then none of the quality is going to be as good as it should be. But there's still going to see, I think we're going to see differences between facilities in the same community, or difference between experience in the same community. So I think that's important to see. I think the comparison of facilities, the comparison of operations is going to be enlightening.
Okay, well, Chair Khan, I want to suggest that we stop here. This is a good transition point, and we will pick up with the data use strategy at the next meeting.
Yeah, that's perfect. Excellent timing today. That should take us to our next agenda item, which is getting close to our closing time soon. So I think let's move on to the next agenda item. Today is the public comment. We are on anybody in the north, Leslie, for a public comment.
Let me just mention that if you are just calling in, you should be hitting *9 to raise your hand if you want to speak. I haven't seen, oh, we have panelists with their hands up still. Has Commissioner Bond and Commissioner Slonim spoken?
Why don't I do this? Let's wrap up the public comment and then we can come back to our commissioners.
Okay, that sounds fine to me. Hit *9 if you would like to speak for public comment. I'm not seeing anything.
Anybody in the south or online from the south?
I don't see anything from the south or the north.
All right, thank you, Leslie. Let's go back to the commissioners.
Can I just say one thing also?
Sure.
If somebody listening in does want to put something in the record, they can always send us an email to ppc.nv.gov, and we can put it in the record if they don't want to speak online, and it will be posted and shared with the PPC.
All right, let's get back to the commissioners. It was Babette and Dr. Slonim. Babette, you want to go ahead?
I think I just didn't put my hand down. What I would like to do today is make sure we get this quality agenda onto our PPC meetings, and the process for that is what I would like to know.
No, I agree with that 100%, because if it's not on the agenda, we won't be able to comprehensively discuss this case. Leslie, could you please make a note of a formal request for an agenda item for our next meeting, unless somebody has any objection?
Was that agenda item to discuss quality of care? Is that what it?
Babette, you want to elaborate a little bit?
Yes, I'd like an agenda item based on today for what quality indicators does the state receive now, and how are those, what transparency is there about those? And then Dr. Khan, you had some suggestions, and I think so did Dr. Slonim. So we could review what is the current, and so did Michael. So we have 4 people that know that there's some quality out there, quality measures out there. We don't know how they're reported to the state. We don't know how transparent they are. And so can those serve as a good benchmarking data set, or initially, and are they reportable in some way that we could do comparisons?
So I think to your point, if I may, if we can get data from other states, as was suggested earlier, what are they doing? And then get the CMS criteria also. And then we have a joint commission expectations also from the hospitals regarding patient, some parameters of quality. So whatever data is out there, federal, state, private sector, around the country, if we can get those put together, then we can see what is feasible to put in place in our state.
Yeah, and what we already, and we do some of it now. So how do we make it more transparent? So
right.
Not just the collection, but the reporting out. Thank you.
Correct. Okay, Tony, you had some comment?
Thank you, Dr. Khan. I'm not sure. Are we entertaining suggestions for agenda items? Is that what we're doing now?
We can, yes. If you have some suggestions, then we will make a note for next meeting.
Great, that would be awesome. I think that there's a couple of things that I'd like to have conversations about more deliberately as a PPC, and they relate to the quality spectrum. I think we are struggling, as we've talked about before at Patient Protection Commission, about the challenges related to workforce, and certainly related to not only the cost benchmarking exercise, but also related directly to quality of care and access. And we struggle in that conversation. I think a second area of focus for us on quality, given our recent rankings as dead last as a state in the nation, is mental health and addiction, and what that looks like, an important responsibility of the Patient Protection Commission to assure that we're addressing that. We simply don't have the infrastructure that we need. So I'd proffer those two as suggestions for us to consider.
Thanks, Dr. Sloan. Leslie, could you please make a note of this?
Yes.
Okay, and just to reinforce what Dr. Sloan is right, we have talked about mental health at length in our former commission role. So a lot of data was collected at that, not data, information, I should say, was collected. Maybe some of that can be also brought to light when we do discuss this in the agenda item next month. Any other comments from any other commissioners?
Commissioner Winkler has his hand up.
Thank you. Yes, this is Tyler Winkler. There are some statutorily created responsibilities for the Patient Protection Commission. And I was thinking maybe if there's an agenda item for next time, we might want to talk about either extending the time of meetings or perhaps making a separate work group or something to make sure that we're able to give full attention to the cost growth benchmark as well as our standing responsibilities. So maybe put that as an agenda item that we can touch on and work through. And then I do know we want to discuss the bylaws at the next meeting. I don't know if there's any special process, if we need to submit amendments or how that would work. Leslie, would you have more clarification on that?
I can defer to our attorney on that. Suzanne Sliwa, are you on right now?
Yes, I am on right now. And I'm sorry, Commissioner, if you could repeat your question.
I know I had submitted some questions about our bylaws, and I think Leslie said that someone else had suggested an amendment to the bylaws. I was wondering if there's a specific process for that. Do we just bring it up for discussion at our next meeting?
Well, I know that, and Leslie and I have had several email discussions about the bylaws specifically. Probably the best way to do that is to put an agenda item on regarding the bylaws, either for discussion if you just want things to be discussed, or for discussion and action if the commission is looking to make changes to the bylaws, make additions to the bylaws, approve anything. So the best way to do that would be on an agendized item, a specific bylaw item. Bylaws are a big issue, and I think it would be best to have specific agenda items on the bylaws rather than just have it be in a general discussion, because I think that could get pretty involved.
So if I may, I agree with you. We have to see how our timing goes in each meeting. Like you said, bylaws discussion could be a little prolonged, and rightly so, because that's a long-term sort of directive for how the commission should function or not function. Mm-hmm. So I agree with that part, but we already have 2 additional agenda items and future presentation by the ballot group. So if not at the next meeting, we could still put it on the agenda at the meeting after, if that's okay. And Leslie, you could please make a note for the meeting after the next meeting to have some time allocated for the bylaws.
So to be clear,
review and recommendation.
To be clear, you want to discuss the bylaws in the April meeting, not the March meeting.
Right, because we already have 2 significant agenda items recommended by Babette Bond and Dr. Slonim, in addition to the ballot follow-up. So I think that those 3 items may take significant time to do justice to those discussions. And to do justice to the bylaws discussion, it's important that we spend some time on that. So it's better if we do it in the April meeting so that we thoroughly discuss the bylaws also.
Dr. Khan, can I just make sure I understand one thing? I think I'm okay with all that, but we left last meeting with the idea that the bylaws were coming back because I hadn't had a chance to review them, and Flo, Commissioner Khan had to abstain because she had not either. So I think we should get back to that, the bylaws in a complete way. I felt like it was a preliminary approval, and I do have an amendment for it. So I will do whichever meeting you think it's best, but I think my hope is that we can amend them.
Yeah, I think there's no problem in doing that once we bring it on the agenda.
Right.
And we can make the amendments by vote of the commission or consensus, whichever is feasible. So I think you're right. So we should do that. And if amendments have to be made, they will be made based on the input of the commissioners. Any other comments from any commissioner?
Yes, this is Leanne McAllister. I wanted to make a suggestion. As wonderful as the presentation from the Department of Public Health was this morning, my recommendation would be that we put all such items in future agendas secondary to the cost benchmark presentations from the ballot group, that's our priority, so that the first 90 minutes are dedicated to that priority, and then any other agenda items come later in the meeting.
Thank you. Any other comments on this? I personally don't see a problem with that. Anybody else in on the commissioner's side?
Chairman Khan, this is Flo Khan. The only thing is, if there are proposed amendments to the bylaws, can we see those ahead of time?
So for that, I think Babette and one of the commissioners talked about it. So then they would have to submit possible amendments, maybe in advance, so that we can review them and then just vote on that.
As I understand it, what Attorney Sliwa said, you will drop your amendment. They will review it, meaning the the DAGs will review it, and then it will go to the chair, and it has to be 14 days prior to our next meeting for him to review, and then it will go out to all of the PPC prior to the next meeting that it's scheduled to be discussed. So
Okay, that's
everybody
very
should
helpful.
have a time to write whatever they want to propose for their amendment. They will present it during the meeting that it's agendized on, and then you will vote yes or no if you want to agree with those amendments.
Great, so
Is that
no
correct?
pressure on the commissioners to submit their amendments ASAP to
Well,
follow
they
the
have to
procedure.
submit them to me apparently because of open meeting law. They have to come to me, and then I will send them to the attorney, and then we
Right,
go
so
from there.
they should come to you within 2 weeks, you said?
Well, yes, if you're going to table this conversation until April, they have a little bit more time, but it has to go to you 14 days prior to the meeting that it's agendized for, because that's what it says in our current bylaws. So
Perfect, so we have ample time for the recommendations for any amendments before the
yes,
next.
if you're going to do it in April, you do have some time, but I would suggest not waiting till the last minute.
Correct, and I agree. All right. Any other comments, opinions, suggestions?
I'm sorry that I have one more to say. I get all that, Leslie, and I will do it. So Commissioner Bond speaking. Sorry, Dr. Khan, I didn't wait for you to call me. I will do that as quickly as I can so that you have my at least. But my other response is to Commissioner McAllister and comments made by Commissioner Winkler. I don't think that the benchmarking is the only thing that the commission was supposed to do. So I think to Commissioner Winkler's point, there's a pretty robust authority that the commission has, and I think that we should definitely get through this benchmarking program that's been assigned to us. But I know it's not the only thing that's been assigned to us. So just want to make sure the agenda does not have 2/3 and 30 minutes for other items. I think it should be 1 hour.
Sorry, you're cutting out. Commissioner Bond, can you repeat some of that? You were cutting out.
I'm babbling too. So I would like us to have more balanced agendas that are part cost benchmarking, and some of the other agendas that the Patient Protection Commission has the authority and the actually assignment to do, as Commissioner Winkler suggested. So I would not support 2/3 being about benchmarking. I think that we need to be a little more balanced in the agendas, and let me know how I can help with that.
Point well taken, Leslie. You've taken note of that.
Got it.
All right.
Thank you.
Any other comments from any commissioners? Hearing or seeing none, then I guess we'll take a motion to adjourn. Do you have a motion to adjourn?
I'll move to adjourn.
Second?
Second.
Okay, anybody opposed? All right, motion carries. Thank you, everybody. I appreciate your time, and I'm glad we were a little ahead of time, so you guys can have lunch now. All right, thank you very much.
Thank you.
Take care. Bye.
Bye.